Perfect.
Good evening, everybody, and welcome to our webinar tonight, Rural Update for Stroke Hyperacute Interventions, commonly known as Rush In. My name is Jenny Pearson. I'm an Education Officer for the Primary Health Network. Before we go any further, I'd like to acknowledge the traditional custodians of the land that we're meeting on today and pay respect to elders past, present and emerging. Our presenter tonight is Dr. Carlos Garcia Esperon. Carlos is a stroke neurologist at John Hunter Hospital. He has presented extensively in regional and rural centres in New South Wales on the role of telethrombolysis in stroke management, educating healthcare practitioners in its role in acute stroke treatment. We also have Jacqueline Binney on the line, who is going to assist with our question and answers during the evening. So don't forget, if you would like to type in your questions, just go to the question box and type them in, and we'll endeavour to get to all of them as we go. There will be an evaluation that will pop up at the end of the webinar, and we would really appreciate your feedback. This webinar is being recorded and will be put in the PHN's education library within the next 24 hours. Thanks, Carlos. I'll leave it to you.
Thank you, Jenny. Thanks, Jackie, for helping on this. Sorry, running late. Actually, the Russian title fits pretty well. So a few parts in our talk, so definitely I'll open for questions while we are transitioning. We start. So this is the learning objectives and copy and pasting. What are we going to go through? And this is how is going to be the structure of today. I'm going to start with the hyperacute stroke, which is the bit that we are extremely passionate about. From there, jump into what's this New South Wales Telestroke Network, what's all this about, talking a bit about the pre-hospital phase. Then TA, minor stroke management, and if we have time even to a clinical case. It's going to be a couple of clinical cases. I hope that we have time to go through everything. You may notice a bit of an accent. I always put this as kind of a disclaimer. I'm from there. I'm from Galicia, a beautiful part of Spain. If you have heard about El Camino, definitely is worth to do. And if you haven't, you should Google it. But yeah, the problem is that it has been a long day of clinics probably for everyone, so the accent gets a bit thicker. Anyway, we'll go through that. We know that with the stroke, time is brain, and we heard that thousands of times. Actually, one of my colleagues years ago, Jeff Saver, actually even quantified this. Not for that's relevant, but probably to show you how the impact of every hour, every minute, and every second has on the patient and patient's outcome, and how that implies more rehab and worsen outcomes. So definitely time is brain, we know that. I would like to run all these around the case. I would like to run around Mr. X, which is a patient that is pretty similar to many patients that we've seen every day in the clinic. He's a 77-year-old male, independent, with probably a bit elevated alcohol consumption of 4 or 5 beers per day, on atrial fibrillation on the Vigotram for the last 5 years. It was stopped. Family doesn't know why. Yesterday he was at the pub and he developed a headache. We're finding difficulties and right side weakness. So that triggered a call to the ambulance, and the patient arrived at the hospital with 75 minutes from onset. This is a scenario that all of you and myself and everyone will see, as unfortunately 1 in 6 Australians will suffer a stroke. And I'm not sure how many of us are in the call at the moment, but that means that some of us, we will. Some of us will be the patients at some point. Unfortunately, there's around 50,000 new strokes each year in Australia and 15,000 in New South Wales. And I'm going to focus mostly around ischemic stroke, the clot strokes, as we have much more therapies to offer as the early reperfusion therapies. Patient arrived to ED. So the initial ECG blood tests are normal. It is important as some especially, we don't stop our routine in the hyperacute phase to take bloods, but it's important just to be sure about the INR of the patients, for example, or sometimes some patients, they have a raise of troponins at the time of a stroke, as they can have a myocardial infarction as well. At the assessment of the neurologist, it was found to have a left case preference, so that you can see case preference in these big hemispheric strokes. A right homonymous hemianopia, so patient unable to see through the right, facial palsy, right hemiparesis, so weak on the right, and a mixed aphasia, and IHSS of 20. NIHSS is the stroke scale that we use for assessment, and actually it ranges from 0 asymptomatic to 42. 20 is a high score, very high score, identifying that the patient probably is having a very, very significant stroke. There is no time here for, I think that there's we don't have the chance to be able to interact with the questions, so I'm going to answer to the questions that I'm popping in. But definitely good to think how you would do it. So the patient arrives, you're there with the patient. What kind of brain imaging, what modality would you organize? There are a few options there. I give you a CT scanner, a CT angiogram, a CT perfusion, an MRI maybe, I wish, a cerebral angiogram straight, or perhaps you want to go through a combination of tests. And the reality is that what we do is a combination of tests. We tend to do in these hyperacute strokes a combination of a CT angiogram, and a CT perfusion. And I would like to explain you why we do these three techniques. So the first step is the non-contrast CT. Why? Well, we need to rule out that the patient is not having a hemorrhagic stroke. That's something that is, sometimes there might be some signs in the assessment that might guide us towards a hemorrhagic stroke, but still 80% of the strokes are ischemic, meaning when the patients are on a NOAC, still is more likely that they are having an ischemic stroke due to a failure of a NOAC rather than a hemorrhagic stroke. So please, pretty important on that. Here, there's little to say about the non-contrast CT. Probably the patient had an older stroke here on the right frontal area, a bit of atrophy, but pretty average for an age of 77. The CT angiogram, I'll give you here in the coronal view. This is the left side, and in the left middle cerebral artery, you can see an acute stop. So the patient is having a middle cerebral artery occlusion in this proximal segment, what we call the M1 segment. And important always to keep in mind, we always assess the vessels extracranial. This is not the best picture, but I can tell you there was no extracranial occlusion. Some patients, they can have a concomitant intra-extracranial occlusion. But the important bit here is that that patient had an initial scan that I showed you on our patient, the non-contrast CT looked fine, meaning there is no hemorrhage, first step, and there is no obvious ischemia. But the reality is that for ischemia, it's not everything so obvious in the real life. So the reality is that here I put you three patients. Patient in the left, scan looks normal. Patient on the right, you can see a stroke on the right basal ganglia, a subacute stroke. And this patient in between, if you are guided by the circles, you might see that in this area, probably you cannot see the cortex and the sulci as well that in the contralateral side. And even with this, not probably the best picture, but probably the basal ganglia structures, they don't look as clear as the contralateral side. What does it mean? That means that all that part of the brain is already dead. That means that it's still alive. That means that it's on the way. Is safe to thrombolyze? No. And that's the problem. The brain dies as a continuum, isn't it? So that means that there is no clear cutoff, yes, no. And the non-contrast CT is not good enough. So that's why we use different techniques that is called CT perfusion. Give us a much more better idea about the dynamics and the blood flow. So the CT perfusion is that rather than doing a single snapshot as we do in the CT angiogram with the contrast, we record a movie for 60, 70 seconds. So we can see the path of contrast through the brain and how the brain gets the enhancement with the contrast and then how it's washed out that contrast. This process was matched with follow-up MRIs, and the MRI following up, matching with the MRI, we are able to identify different thresholds that give us a good idea of what's the established damage in the brain at that point, what we call the core, and what's the part of the brain that is at risk. But if we are able to recanalize, to dissolve or remove that clot, that part of the brain might come back to normal, what we call the penumbra. And this is how the imaging look when we do, and this is actually the scans of this patient. And they are pretty complex and they are difficult to interpret and analyze. So that's why we use softwares that they have been developed with our input towards merging all those maps that are fairly complex to design to interpret towards a more simple red-green stop and go maps. They are the core penumbra maps. So here, the part of the brain that is already very likely damaged and irreversible, you can see it in red, and the parts of the brain that they are at risk. But if we unblock that MCA, middle cerebral artery occlusion, might recover and come back to normal, and that's in green. So here is a beautiful and perfect map of a patient that has a left MCA occlusion with very little damage happened, actually 5 milliliters, and a lot of brain in the left hemisphere at risk, and that can be salvageable. So that's why we do all these techniques. Why? When a patient has a vessel occlusion, that part of the brain is still holding by what we call the collateral circulation. And the collateral circulation comes from very different areas, can come from the leptomeningeal vessels, can come from the anterior or posterior circulation. And what's happening is that it's giving some amount of supply to that part of the brain, kind of extending the window of treatment. And that's where it's starting to be interesting, highly variable among patients. Some patients, they have very little collateral circulation, which means in a couple of hours, there's very little tissue to save. And another, they have great collaterals, and the tissue can be even salvageable up to 20, 30 hours after stroke. This concept actually started to come in the 80s with PET studies that show that it's a dynamic process, which makes a lot of sense, that the damage is progressively establishing until there is nothing to save there. So when we are thinking about treating, as we used to treat the strokes 15 years ago, based on a non-contrast CT, would be kind of using that computer every day, the first Apple computer, very, very. But if currently probably you use something more towards the laptop that you can see on the right, and that's how I see how we are using the technology and our current knowledge towards getting the better outcomes to the patient. And most important, being able to tailor the outcomes towards decreasing the risk of treating and getting the better outcomes, and just not treating based on a criteria of 4.5 hours for everyone or 24 hours or whatever. Resuming and kind of in conclusion of this section of why we do the CT perfusion, we work at the John Hunter, we work extensively on the CT perfusion, and my colleagues, especially Professor Parsons, Levi, and Spratt, they were heavily involved on the development of this technique internationally. So we know that those patients that they have what we call target mismatch, which means not a very large amount of brain tissue damage and still some tissue to save, they have a 23 times greater chance of an excellent outcome compared to those patients untreated. However, those patients that already have what we call a large core volume, which means a volume of established damage greater than 70 milliliters, which is a large proportion, they have actually almost like a 50% increase of mortality and 9 times increased risk of having a symptomatic intracranial hemorrhage. We don't thrombolyze those patients. And those patients that they have a small perfusion lesion, like a small strokes, less than 50 milliliters, the majority we can see that they don't have a significant benefit for thrombolysis. And those patients, they don't have any tissue to save, has a 16 times greater chance of a poor clinical outcome and death if treated. So as you can see, and before continuing on this, that might give you an idea of how we change from a very, I would say, basic approach of how the patients were thrombolyzed, especially in 1995, 96, early 2000s, based on a non-contrast CT, assuming a 5, 7, 10% even, but usually around 7% risk of hemorrhagic transformation, to currently targeting towards with perfusion. And our current risk of hemorrhagic transformation is usually around 0.8, 0.9%. So keep those figures from a 7, 8, 9% towards 0.8, 0.9. So remember, coming back then to the clinical picture, we have this patient that the anticoagulation was stopped a few days ago, no clear reason for that, and is presenting in the thrombolysis window with a large vessel occlusion. There is an occlusion on the MCA and a very significant stroke presentation. A few questions here again that probably you will need to answer to yourself. Unfortunately, which is the treatment? What are we going to do? Would you decide to go on antiplatelet therapy route, or perhaps you heparin, thrombolysis with alteplase, tenecteplase, clot retrieval, perhaps a combination? So I might guide you that the right answer in this case would be the last one again. And we would be able to offer this patient the two treatments, the thrombolysis with alteplase and clot retrieval. Thrombolysis is actually delivered at the rural hospitals of the telestroke network, and I will jump to that a bit later, and at the Comprehensive Stroke Center in Hunter, New England, here at the John Hunter. And the problem is that the majority of the patients do not benefit. And that doesn't mean that thrombolysis doesn't work. That means that thrombolysis is not ideal to dissolve big clots. And when you have a patient like that, you can see that when you see the thrombectomy, the clot is actually pretty large. So thrombolysis is great when you have a clot sitting in much more distal and thinner branches. But for these patients, the benefit is usually 1 in 10 patients recanalizes with thrombolysis, which means it's a good plan to start thrombolysis, especially if you're in a rural hospital and you have a long transfer ahead of you, as 1 in 10 will recanalize on the way. Excellent. But that doesn't mean that we will sit and wait for that patient that improves and clinically with thrombolysis. That means that we need always to work in parallel. And when that patient comes, for example, at the John Hunter Hospital, we are already thinking, okay, we're going to draw thrombolysis, and at the same time, I'm calling the INR. And the same happens when we see one of these patients in rural, as part of our telestroke network. As soon as I see the scanners, I contact the interventional neurologist in Hunter, New England. The mean of course would be the John Hunter, but we are across the whole state, so I might be calling out my colleagues in Liverpool, RPA, or Prince of Wales in Sydney. Back to this in thrombolysis, as mentioned, is unfortunately not for everyone. If the patient is on warfarin and the INR is greater than 1.7, wouldn't be an option for the patient. If the patient is on a NOAC and compliant either. Recent surgery, that's a classic scenario, isn't it? That patient that has a knee replacement, the NOAC is stopped and had a stroke a couple of days after in the ward. Unfortunately, that's not a patient for thrombolysis. And pregnancy, there's very little evidence about pregnancy in thrombolysis in pregnant. As said before, the longer the clot, the less likely the recanalization. And actually, this is a very interesting study from a few years ago. And you can see how the likelihood of a clot that is sitting in MCA, that usually is a couple of is like a couple of centimeters. The likelihood is around, as mentioned, on the 15% roughly. Back to our patient. We decided to thrombolyze. There was no clinical improvement. And again, we work in parallel and we go towards clot retrieval. We call it a few different ways. Clot retrieval, thrombectomy, all is the same technique, and is basically what you're seeing there in the pictures. Usually we tend to do a growing access, and through the groin we go up to the brain, and we use these stentrivers. Most of the times there are different techniques as well. We can do aspiration sometimes, and we don't do a stentriver, but majority of the cases we use this. That, as you can see, what does is that we go with a very thin catheter through the clot first. We deploy the stentriver there, and then we open. The stentriver has a radial force, so the stentriver starts to open slowly and get the clot, as you can see, stuck into it. And then we just retrieve slowly the stentriver and put it back into the big distal access catheter, and we just remove the whole system together. We tend to do a growing axis and a femoral axis, but sometimes we do a radial axis. We don't do it so often, as the caliber, the diameter of all the material that we use, and the curves that we have to do to go towards the brain sometimes make it tricky. But yeah, it's something we do sometimes as our colleagues in cardiology. But the most common axis is the femoral one. Yeah, and usually, if a thrombectomy is straightforward and goes well, a single pass gets all the clot. Hooray! Sometimes we need to be doing passes till, and passes till we are able to remove all the clot, which is different if on the clot combination, what the clot is foam. There's a lot of research actually around that and about what's the ingredients and what's the, like, how heavy is in fibrinogen, for example, the clot, and the likelihood of recanalization. So there's a lot of research around that at the moment. Thrombectomy is the most powerful intervention that we had in the modern medicine. This is a slide explaining what's the 3-month outcome of the pivotal trial, found out in the pivotal trials in 2015, comparing thrombectomy versus medical treatment. That would be just thrombolysis. We are talking about disabling strokes, not the smaller strokes or anything like that. And you can see that those patients that they just received thrombolysis, 1 in 4 were back to normal life, compared to those in thrombectomy actually is 1 in 2. And these are, again, the pivotal trials in 2015. We got better than that. And you can see how the effect also in the moderate dependent or bedbound death after a stroke, 21% in the thrombectomy group versus 35% in the medical treatment. So what this tells us is stroke is a terrible disease, but thrombectomy actually is a game change. And in these very disabling strokes, we just need to treat 3 of them with thrombectomy to have a patient going back to normal life, meaning 3 months after a stroke. That is usually the primary outcome that we take as after any therapy. Actually, 1 in 3 patients comes and returns back to a normal life. That means back at work, no symptoms. It's amazing. And this slide always looks a bit funny. The CTP is also important here because allow us to identify those patients from what was the classic window of thrombectomy of 6 hours and push it towards 24 hours. I'll explain this a bit more. There were 2 trials that I put you there, the names for your references, that actually were published in 2018, and they tried to prove what if would be a benefit of thrombectomy in what's called the extended window, like beyond the 6 hours up to 24 hours, in those patients that they still had tissue to save in thrombectomy and in the CT perfusion, like the picture on the left, and not the picture on the right. Compared to those patients treated with medical therapy. And indeed, we find that still in those patients that they have tissue to save, thrombectomy can be beneficial with up to 24 hours, with a number need to treat again 3 to 4. That doesn't mean that this is not time dependent. This is a small minority of patients that they still have such a great collateral circulation that the brain is able to be alive till 24 hours. We know till 24 hours, but this is a random threshold that the studies got into. But again, this is all the patients, they are gonna get a better outcome the sooner we start therapies. But that tells us that still in those patients that have a great collaterals, we can still offer therapies up to 24 hours, which means for those patients presenting with big, large stroke symptoms, we need to triage up to 24 hours. Back to our case, thrombectomy was performed. Picture in the left, this is a coronal projection. This is the internal carotid artery. This is the MCA, M1, and we put the stent retriever. With a bit of imagination, you can see these 3 dots. This is the distal, actually, mark of the stent retriever. It's done by that, so we know exactly when the interventional neuroradiologist deploys it, we know exactly where we are placed. So we know that the distal is here and probably the proximal bit would be somewhere here. And actually, it was a very straightforward, I'm not sure it was a single pass. I think it was a couple of passes. Open the vessel. You can see all the branches coming here on the MCA. Well, before you could just see silence. And this is all the pieces of clot. And this is usually how it looks. You don't get such a big, large, beautiful clot. You get a few different pieces. All right. Great outcome. This is the follow-up imaging, non-contrast CT. You can see something happening there in the left basal ganglia, but the MRI shows it much more clear. And most importantly, great outcome. I think that the NIHSS of 24 hours was 2 or 3, meaning very mild symptoms, just facial droop and still mild, subtle, were finding difficulties. Of course, I'm presenting you a case of a patient that did great, of course, but this is just to show you how powerful can be the therapy. as it's amazing. You can see how something that we've seen hundreds, and still every time some patients, they have this kind of miraculous improvement, and they just pull off the clot and suddenly the patient starts to talk and move the right arm and the right limbs. Is just incredible. Moving towards a few different questions. I mentioned that we thrombolize without the place, but perhaps you might heard about tenecteplase, and you are very familiar of the use of tenecteplase in all the cardiac literature. So can we thrombolize with tenecteplase? Well, not yet. We wish, we would like to, and we are doing a lot of research around that. Actually, the research is Australian-based and Australian triggered, which is something that we are very proud of. And this is the results of our trial that we published in 2012. Mark Parsons was the lead author, comparing tenecteplase versus TPA. It was a small group of patients, but actually we can see how the patients on receiving tenecteplase were more likely to improve and more likely to reperfuse at 24 hours. We know that the physiology of tenecteplase definitely is more favorable than alteplase, and actually is extremely appealing how we can give it as a single dose as a bolus, but we don't have still randomized clinical data to give to ischemic strokes. So currently we are randomizing into clinical trials, which might be impacted, as some of you might heard that there's a worldwide shortage of tenecteplase. So currently the use of tenecteplase worldwide has been redirected strongly towards cardiac patients, and especially in rural sites where the access to PCI is more limited. Another question that might came to you is like, well, Carlos, you mentioned that thrombolysis recanalizes in these larger strokes around 10-15% of the times. So why we don't go straight to thrombectomy and we stop and we don't thrombolize patients? This actually has been a matter of study, and there's around 4 or 5 randomized clinical trials that they were trying to ask this question. And I'll put you here the results on the top left, and I'm happy to guide through and to go through. They compare different outcomes as 30 days. They compare using what we use, the modified ranking scale, which basically means 0 to 2 means the patient is independent, 0 to 3 the patient was after a stroke independent or requires mild assistance. There was no significant difference in outcome between the primary outcome, modified ranking scale 0 to 2, meaning independent, excellent outcome, or mild dependent, which means there is no evidence to skip thrombolysis. And this is important, as this has been done in comprehensive stroke centers. And if we expand these results towards rural sites, the magnitude of the benefit of thrombolysis starts to increase, as the access to thrombectomy can be 3-4 hours down the track, or even more. Like Jackie's online and she can tell how long does it take an average transfer from Armidel. It takes a while. So definitely that's something that is important to keep in mind. If the patient can be thrombolized, should be thrombolized. This is a bit of the timeline of the reperfusion therapies. And I put you that just to see how everything started in basically 1995 with those pivotal trials. But the things get a lot of momentum over the last 10 years, and how we started to do clot retrieval in 2015, but just in a 6-hour window. And then the advanced imaging actually helped us to extend the thrombolysis window up to 24 hours. And I didn't mention about that, but actually even the extended CT perfusion helped us to extend the thrombolysis window up to 9 hours in very highly selected patients. I didn't want to mention much about that, as this is still something that we don't do very often, but from time to time we do. And this is the reality in what we live. These are examples of very long transfers from different rural sites towards comprehensive stroke centers across Australia. Here in Newcastle, I put Moree because it's the farthest away from us, but we would have Armidale and Tamworth, not much to a similar distance. And you can see how Longreach goes to Gold Coast, Cairns to Brisbane, Darwin to Adelaide. I think that this is gets the top distance. Perth to Broome, Hobart to Melbourne, and many others. And this is currently what's happening all around Australia. And I put that to start to talk about, okay, that tells you that there's something else beyond the comprehensive stroke centres there is. And in New South Wales, there is a New South Wales telestroke network. As you can see, the window for triaging patients increase, which create an increase in the volume of patients requiring triage and an increase of the volume of patients receiving reperfusion therapies. In New South Wales, just to give you a bit of history, everything started actually the first site was Taree in 2013. It started as a pilot project that was created by Chris Levi and Mark Parsons in Hunter, New England, and created the pilot project of the Telestroke network. And that started in 2013 and rapidly took sites as Tamworth, Armidale, Murray, and then Mid-North Coast. That pilot project and the outcome data from that pilot project made the case and was the cornerstone for developing a New South Wales telestroke network, which actually started in March 2020 and started in Coffs and Port Macquarie, and it started with these two sites and currently is providing services to 23 hospitals in rural Australia. It is exciting. I will show you and guide you a bit through. It's exciting for the reason that it's providing access to the stroke neurologist almost everywhere in rural Australia. Exciting because it's a roster of a combination of multiple neurologists from different hospitals. It's led by my colleague, Ken Butcher. He's based in Sydney at Prince of Wales. But you have John Hunter representation, myself in a much younger picture, my colleague and boss, Neil Spratt, Alvin, and we have then neurologists from Gosford and other neurologists based in Sydney. But most interestingly, we have a clear representation of our colleagues that they are working in rural sites, and as you very well know, Lisa and James, or our colleagues in Wagga, they are part of the New South Wales telestroke roster, mostly around keeping a huge footprint and doing most of the job on their sites, but also participating on the weekly telestroke meetings, which is important. I think that that's something that one of the why I do enjoy being in New South Wales telestroke network is that there's a strong how can I say it? I just lost my words there. There's a strong push towards education and enhancing the local resources. So that's very important. As otherwise, we need to get more neurologists in rural, and here in Hunter, New England, how overstretched we are, and this we are creating this as well as giving access to those rural stroke neurologists and to support them and to enhance more neurologists going towards rural sites. This is how it works. Patient comes with a fast positive, go to the rural site. Let's run a case. Imagine that the patient goes to Armidale. Initially, they flag to us by using a few tools, start to contact the New South Wales telestroke neurologist. For example, tomorrow I'm on call for New South Wales. Decide what kind of imaging should we do. Yeah, let's do a CT angiogram, a CT perfusion. We do all those techniques in the rural sites. In all the sites in New South Wales telestroke, they have access to CT angiogram and CT perfusion. And then together with their ED doctor and the ED team, we review the imaging together if there's time for it. But most of the times we try at least to discuss the imaging. And we decide what are the best therapies for that patient. It can be Thrombolyze, transfer for clot retrieval, both. Is a hemorrhage and needs lowering blood pressure. And we then liaise with interventional neurologists at the Comprehensive Stroke Center, and ED facilitates and supports with retrieval the transfer of the patient. As mentioned before, that I was stuck on my words, a bit of a long day, sorry about that. Education and training has been crucial and has been one of the bits that I think that makes very different telestroke in New South Wales from other networks. With a very strong component of education and developing what's called the ASAP tool. That is a very simple tool in the intranet that would guide the ED physician or the ED reg or nurse towards, shall we call the stroke neurologist or not. And also we support in the education and the workflow. We develop, my colleagues here in Newcastle, they develop also VR modules to help on the training locally. This is how it looks. This is the stroke. This is the triage. It's the ASAP tool and looks something like that. Actually, is a very click, point and click kind of template that will give you, get you towards a final decision, call, not call. If you don't call, you decide to follow your ED pathway. That means that the patient is not candidate for hyperacute therapies, and the call definitely will trigger to give you the phone number and contact us. Realistically, that template is putting together the time from the onset, the severity of the symptoms, and how well the patient is doing. And for that, we use the modified ranking scale, but there was just broken into questions. And sometimes we like also to think about the DBS. DBS is a very simple and easy way to identify a patient that still is doing well and needs to be contacted for hyperacute therapies. We acknowledge, and all of you, I'm sure that you agree with me, population is definitely aging. And the calls that used to be a few years ago, the average call on the early 70s now is getting towards almost 80, 77, 78 years old is the average call that we get with a patient with a stroke. And there are very different range of patients at that age and older. So a very easy and simple way from an ED perspective, PCED is asking the patient is still driving or doing domestics, banking, shopping, and that's what we call the DBS. And that already gives you, if a patient is still able to do most of these activities, it's going to be someone independent and doing well enough to be able to be candidate for all the therapies. Because unfortunately, there is no evidence that the therapies that we are offering as clot retrieval might have any benefit in those patients that already are dependent at baseline. Important, age is not a restriction. Actually, we treated a patient who was 100 years old. But again, this is a 1 in a million. We know that there are not many patients at that age that they're still like her. She was independent, driving, living by herself, requiring no assistance whatsoever, managing her finances. Why we are not going to offer these therapies? This is the numbers of New South Wales telestroke, not to date, but almost. You can see there, 26th of July. Busy. As you can see, 2,400, almost 2,370 calls, 469 reperfusion recommendations, meaning patients that were thrombolyzed and or clot retrieval, and 23 sites. And you can see them there. This is beautiful. You can see the activation dates there, starting with coughs and port. And you can see how quickly till the last site was Broken Hill. That actually happened, a month ago. And the bubble, the circle, gives you an idea of the larger the circle, the larger the volume of calls. Of course, it's artifacted because those sites that they studied, the sooner they have definitely more and more calls, of course, because they started almost like, half a year earlier than others. But yeah, interesting. And you can see how 100 New England Mid-North Coast are busy sites, and they are definitely very, very active on New South Wales. How well are we doing? 58% of the cases are acute ischemic strokes, and you can see here a bit of, in this funny graph, how the calls comes from in hospital strokes, emergency department, how a percentage of them are stroke mimics, which is fair enough, how 58% are ischemic strokes, and then here you can see how it was breaking the treatments. Where are we? How active we are? I'm selecting here the Hunter New England sites. I'm very biased on this, and you can see many in Tamworth, Armidale, and Murray. You can see that they are active sites, especially on reperfusion therapies and reperfusion recommendations. So already all this starts to sound like, okay, if you are not based in these sites, what you should do? Well, you should contact these sites straight away. You should doing a non-contractility before transferring the patient towards one of these sites. If the patient is having a stroke or stroke symptoms and you think that the patient might need reperfusion therapies, a non-contractility is not going to help you at all. It's probably just going to delay something that is time dependent. So I would suggest you just contact these sites. For example, if you are like, I don't know, there are many, but for example, I don't know, Narrabri, Glen Innes, Inverell, Tenterfield, many others. Definitely contact your closest New South Wales Telestroke hospital, as that would be the best way to go in getting access to reperfusion therapies. Important, these 4 sites, they deliver 24/7 thrombolysis, they connect to the stroke neurologist, and there are pathways to quick and rapid referral and transfer to clot retrieval at the John Hunter Hospital. How fast they are? They became very fast on this. Actually, their timings are not far away from what we do at the comprehensive stroke centers. And this is something that is amazing. The door to needle across New South Wales Telestroke is 66 minutes. That means patient arrives, identified that has a stroke, they do the ASAP tool, they call us, go to the scan, we take a look at the scans, we assess the patient together, and we find an agreement about thrombolysis, and we start to thrombolyze. 66 minutes is not bad at all. The gold standard in a comprehensive stroke center with dedicated stroke teams is keeping it below 60 minutes. At the John Hunter, realistically, I think that we are in the 50 at the moment, meaning, and we have a dedicated stroke team to that, which tells you this is impressive. And if you look at it, 36% actually keeps that criteria that is applicable to comprehensive stroke centers below 60 minutes. This is fabulous. How busy we are? Look, the average of calls varies dramatically among days, but definitely the average is seven calls per day. And as you can see, we tend to run around 4 calls per day, which every call is an hour consult, 60 minutes. We decline 32% of the calls based on very mild symptoms or way beyond or very unlikely stroke. So we always like to go to the point. The ASAP tool is the first place to start, as if the ASAP is telling you not to call us, it's very unlikely that it's going to be a stroke. Yeah, there is the median consultation, 56 minutes. Yeah, and you can see even like there's a lot of information more here that we can digest. As you can see, what I'm trying to show you is the level of how much we analyze the data. We analyze it for trying to improve the quality and trying to make it as homogeneous as we can. And very interesting, you can see how all the sites under the same training, they start and they are extremely homogeneous. It's surprising how everyone thinks that their site is very unique, very specific, and then reality is that, yeah, there's uniqueness and special features in every site, but everyone takes this on board the same and is so engaged. And reality is that everyone, performs very similar. And these are 23 sites, different volumes and different resources. Back to close to from New South Wales Telestroke to what happens close to the John Hunter Hospital, we have a direct New South Wales direct neurologist bypass. And that is a 90-minute bypass, which if we get a call in these 90 minutes, New South Wales ambulance identifies a patient with stroke symptoms, they will call us straight at the John Hunter Hospital, and they use this Hunter 8 scale. These are 8 items of the NIHSS scale, the neurological assessment that we use, and we train the paramedics on this. Interestingly, again, this is a pilot project that was started in the John Hunter Hospital, and this is currently actually on the process to go towards the state, and everyone in the state in New South Wales will be using the Hunter 8 in the pre-hospital space to identify those patients that they might benefit for treatments, but especially large vessel occlusions. These scales are very focused on identifying those patients with big clots likely to benefit for thrombectomy. These are the most severe strokes. And actually, the Hunter-8 score of greater than 8, just for as a curiosity, is able to identify a patient with a large vessel. 50% of those patients are going to have a large vessel occlusion or a large hemorrhage, meaning patients that they need both scenarios to be bypassed and go straight to the comprehensive stroke center. This is how it looks, the bypass that is currently sitting in around the John Hunter area. And basically it's a combination of those facts that we already talked before. How well is the patient doing? What's the time window? And that guides the paramedics towards not calling or calling us. And that has a direct communication, paramedic, stroke neurologist, or a stroke fellow. I'll stop here for a minute if there's any questions from the audience.
Alice, it's Jackie here. I do have a question from Andrew. Is there data kept about the time from symptom onset to arrival at a telestroke site? And I can say yes, there is. And will that data be used to decide on rolling out the telestroke service to other sites?
Good question, Andrew. I think that currently the 23 sites that they are part of it, and I'm rolling back, captures pretty well those sites that they have enough volume to be able to go through a training process and getting all the devices, for example, CT perfusion on site and all these things. I agree with you, and that some areas, especially I always think on the north of Hunter, New England, and all the Mihai tablelands, how challenging can be here, and how the driving distances here can be terrible. Tenterfield, Narrabri, they are hospitals that are far away from, especially Tenterfield or Glen Innes. Still, the number of patients that they would see with a stroke is so small that going through a whole process might be quite challenging, I guess, and just not challenging, but it would be difficult to get everyone on board, getting radiographers trained. It has been challenging, and Jackie, you might want to comment on that, also to getting trained radiographers on these sites to be able to cover a 24/7 roster and able to do perfusions.
Yes, correct. So there's a few different criteria that a site needs to satisfy to become a New South Wales telestroke site. And I don't think there are plans to add it anymore at the moment.
No, I think that these captures, but I think that we keep up, especially at least in Hunter, New England, very open eye to any other areas if required, but doesn't seem to be coming. Any
and I
other
also
questions?
just mention that the ASAP tool is also used for inpatient stroke calls. So if you suspect that an inpatient is having a stroke and a rapid response is called, then the medical team responding to that will be now performing the ASAP tool at the telestroke sites. So Manning, Armidale and Tamworth, Moree soon again. And then that will help guide the treatment, whether we involve the neurologists immediately or we follow our local pathways.
Thank you. No more questions? Jump into this next section. Okay, so that has been quite a lot on focusing on the hyperacute end. But what happens with the patient and the post-stroke care, especially in those minor strokes, TIAs? What are we going to do? I would like to focus more around the minor strokes and the TIAs, as this is quite complex. This is the patient that is discharged from ED or that comes to your GP practice that we haven't heard about, we don't know about, and these patients are at risk of having another stroke and a stroke recurrence. Important, most of the TIAs are minor strokes, just depends how hard you go on the imaging. And it's the spectrum of the same disease. That's how I would put it. It's not, they don't perceive as much more benign a TIA than a minor stroke. It is not. If you do a non-contrast CT, which is what I would recommend, it's very unlikely that you're going to pick up anything on the scan. It's around 4% of the patients. If you go towards an MRI, yeah, you would be able in most of these patients to find a small stroke. But that doesn't need to change. I'm not suggesting here to do MRIs as an outpatient. Patient has to pay for them as an outpatient. We can organize these tests. What I'm suggesting is that it depends. Don't consider the TIA with a normal CT or that patient with transient symptoms with a normal CT scanner that is a much more benign presentation. As urgent treatment is the key. Those patients untreated has a high short-term risk for subsequent events, and actually can be as high as 15% 3 months after a stroke. That's one of the big factors that the big most important data to probably flag here. The treatment is always going to be a combination of the antithrombotic therapy plus blood pressure lowering, statins, and definitely looking for AF and carotid stenosis. And the sooner the better. Symptoms. The symptoms are terrible. Look, running a rapid referral clinic at the John Hunter, I can tell you that the symptoms can be as probably as your impression. The symptoms of a stroke. Some patients are great historians and they tell us a great story and very clear, but sometimes can be just a funny term, or sometimes can be even less than that. Sometimes you don't get even that. Some symptoms are already very highly suggestive. If the patient explains you unilateral weakness involving face, arm, leg, or two of those three, aphasia, hemianopia, or unilateral numbness. But things are starting to look more complex when the patient explains just isolated dysarthria, which usually most of the times tends not to be a stroke, numbness in one limb, or isolated dizziness. It's difficult to stratify the risk of recurrence. And all the symptoms are not equal. I think that's something that I would put there pretty. And if the patient explains a good history of aphasia or hemiparesis, has a much stronger predicting value than those dysarthria or confusion. And ABCD definitely is a scoring system and helps to stratify, but doesn't tell you much about the carotid stenosis or how is the carotid status, or it is a good place to start, I would say, but it's not perfect. Sounds redundant, but definitely it's important to exclude that the patient is not having still symptoms, that the visual fields are normal, that there's no sensory inattention, no dysarthria, or no mild dysphagia. And the reality is that a large proportion of these patients that they look like a stroke, they are not going to be a stroke. And this is very similar to the results that we have in our clinic, in which 60% of the patients that they are sent to the rapid referral clinics are not strokes, and that's how it should be. Meaning, if we don't identify and we don't go through this, we will be missing patients. And the common mimics are seizures, syncopes, functional disorders, migraine with aura, or sepsis. What's more likely a mimic? If the patient explains positive symptoms, as indicates an excess of neuronal activity. It can be visual, motor, and the most important bit, I would say, and I take on the history, is the onset. Everything that is a sudden onset, even if it sounds extremely funny, I will take it as a stroke unless I prove the opposite. And everything with an onset that is progressive is going to be very unlikely stroke. How we are going to prevent the strokes? When a patient comes with a stroke, the mechanism will fit into one of these five. Atherosclerotic, 20%, we'll talk about that. Cardioembolic, lacunar, infrequent, which means unusual causes of a stroke, especially carotid dissections, or cryptogenic, which means, and as you know, after going through all the tests and all the workup, still 30% of the patients remains unknown why they had a stroke. Focusing on each of these categories, atherosclerotic strokes are very important to be assessed and ruled out, and the extracranial vessels needs to be assessed. Most common, the carotids. I'll put you here a picture on the right. You can see on a DSA a carotid bifurcation, and you can see a big plaque there on the internal carotid artery. This can cause strokes due to different mechanisms. It can be occluded acutely, can cause distal embolization or distal hypoperfusion. So all patients with a carotid territorial stroke and an anterior stroke or a TIA needs to have extracranial vessels assessed. Carotids, vertebrals. Ultrasound, fantastic. It's a great place to start. It's available, it's simple, it's reliable, in good hands. The problems is that, well, some patients, their anatomy can be challenging and they can have very difficult windows to be assessed, but the majority will be a great place to start. CT and geography are fantastic, but I wouldn't be pushing you to be doing that. That's something we can do in the clinic. And MR angiographies are terrible, to be honest. They overcall the stenosis. There's a lot of noise. So usually, especially extracranial, are not a very useful technique. Carotid stenosis, who should we treat? Controversy is lessening, in every vessel that is symptomatic, meaning the patient explains you a TIA or has a minor stroke or a big stroke in that relevant territory, if it's greater than 70%, needs to be treated. How? Carotid endarterectomy tends to be most of the cases, and we lean towards endarterectomy, but some scenarios, especially radiotherapy or young patients, we consider stent. What happens if you find an stenosis in a patient, 80%, let's say, and the patient never had a stroke or explained stroke symptoms? Well, it's a difficult question. Actually, the evidences start to grow towards those 80-90% asymptomatic to be treated as well. But this is not solid evidence. It's growing, as I put there, and we are not advocating random screening for everyone or carotid Dopplers for everyone. But if you find that on the way of another investigations, it's worth to probably refer to the vascular surgeon or to us and say, hey, I found this carotid stenosis. Can you help us on management? And if a patient requires, it has a greater than 70% and looks like a stroke, TIA symptoms, that's an urgent. That's urgent. That definitely would need to trigger a call towards one of the neurologists on call or vascular surgeons. Usually a neurologist, a stroke neurologist would be the best place to start and give a call and say, hey, this is the kind of patient that these ones are the ones that are at higher risk of recurrence. How we treat them? Dual antiplatelet therapy for 3 weeks is the way to go. There was a Chinese trial called the CHANCE trial, and that showed the benefit of the combination of aspirin and clopidogrel compared to aspirin alone in those non-cardiomyopathic strokes, meaning patient with no AF, no anticoagulation. That's a different scenario. But if the patient just requires antiplatelets, go for duals. 3 weeks. Point trial based recruiting patient in US, Europe, and Australia showed the same combination of actually 3 weeks is the best combination of aspirin and clopidogrel is superior on preventing events compared to single antiplatelet therapy. These trials actually they compare the combination of clopidogrel and aspirin on 90 days versus single antiplatelet therapy. But what they found is this. They found that the major benefit of the combination happens within the first 3 weeks. And after that, there seems to be more a plateau. And there was less benefit of the combination of both antiplatelets. And what they saw, and I didn't put it here, is that the hemorrhagic risk starts to increase. So a sub-analysis showed that the 21 days, the 3 weeks after stroke, is the sweet spot for dual antiplatelet therapy. Again, in those non-cardiomyopathic strokes, if the patient has atrial fibrillation, needs to be anticoagulated, no need, no benefit of adding aspirin or clopidogrel in that subset of patients. Jumping to the cardiomyopathic. If it looks like a cardiomyopathic stroke, if the patient has AF, already fantastic. If it's on warfarin, definitely switch to a NOAC. If it's in a NOAC, what you should do, that's difficult. There's not much evidence. We tend to switch to a NOAC that acts in a different route. If you have a factor 10A, you can switch to dabigatran, for example, or the other way around. If you have a stroke or a TIA, and as a part of the workup that we need to assess the heart rhythm, 24 hours ECG is a very easy and great place to start. I have actually one of these in the clinic, the Cardia ECG. They don't pay me, I promise, but I got it as is FDA approved. Cardiologists use it as well. It definitely is great to triage. Like I'm sure that most of you run very busy clinics, and this is a very efficient way. As you get you can see a single lead ECG just with putting 2 fingers on each side of the device. You might get a great trace, and that helps you to identify what patients are in atrial fibrillation, and if the device detects atrial fibrillation, I then do a 12-lead ECG, but I don't have the time or the resources to do a 12-lead ECG in each patient. Apple Watch, again, is FDA approved as well. You might consider, if the patient has one of them, use it. When they come to the clinic, we tend to move towards longer periods of recording. You will see that we write in our letters about a 30-day hardback, and that's something that we tend to do quite often. This is an Australian device in the left, and it's a 2-lead ECG. And in a minority of patients, very highly selected, we decide to perform a loop recorder implant that is able to identify the heart rhythm up to 3 years. Just a minority, as the resources that we have across Hunter New England to get these devices is limited, and across Australia is also extremely limited. Advantages is PBS, and the patient doesn't need to pay anything through it, but is the logistically we can just offer this to a minority of our patients. If the patient doesn't have a carotid stenosis or a cardioembolic stroke, might have a stroke, what we call a lacunar stroke, which is the classic stroke secondary to a stroke on the small vessels, secondary to the combination of the risk factors that we are very familiar with, especially you can see on the left, smoking, sugar, hypertension, hypercholesterolemia. In these ones, yeah, we need to tick all the boxes, taking a look at the heart, taking a look at the carotids, but the most important bit is going to be the prevention, the risk factor control, the antiplatelets. Remember, dual antiplatelets for 3 weeks, followed by single antiplatelet, and statins, high dose of statins, atorvastatin 80 milligrams, rosuvastatin 4 milligrams, our way to go. I tend to lean more towards rosuvastatin for cramps, but atorvastatin is fantastic. I would just suggest don't go to simvastatin, as those ones definitely develop quite a lot of cramps, and they will not tolerate a high dose. Okay, that's an interesting one. You might heard about the PFO closure, of course. Okay, which patients shall we screen? Important to know, PFO doesn't cause strokes. It's an incidental finding, as you are aware, and 20 to 25% of the population has a PFO. But an emboli from a venous circulation might bypass the lungs and can cause a stroke if the patient has a PFO. So actually, PFO screening is indicated in young patients, meaning young stroke patients, younger than 60, with a possible embolic looking stroke, which is affecting the cortex, and no other clear cause of a stroke or TIA. And definitely, if this triggers as a Valsalva, might suggest more a PFO mechanism. We can identify if the patient has a PFO, as you know, with a bubble study at the time of requesting the cardiac ultrasound, with a TOE, or with a right-left shunt by transcranial Doppler as well, that sometimes we do in the clinic. Important. If we start to routinely screen this to everyone, we're going to find a lot of PFOs that we are not going to know what to do. This is just the last step after everything came back normal. And if we find that, we definitely close it. I tend to close the younger patients, the 20s, 30s, 40s. It's a bit more blurred what to do in the patients when they are 40 plus, 50, especially the 50 to 60 is more challenging. As if you think about it, the patient had a PFO for 55 years. If you don't find, as an example, if you don't find a clot on the legs at the time of doing a lower limb ultrasound, you might wonder what's the role of that. The patient that didn't have a stroke in 55 years, and if you don't have a clear Valsalva, if you don't have a clear trigger, so that's something important to keep in mind. In these patients, worth as well to do an ultrasound of the legs, as many times you will find a small DVT that was asymptomatic. I was telling the other day in one of these talks how a young patient actually at the age of 16 had a DVT that wasn't detected. Another thing to keep in mind is in the young stroke patients, look for these triggers. Triggers of an injury or triggers of on the neck might cause a carotid or a vertebral dissection. Very common one, chiropractor. Sometimes after a very vigorous massage might cause some damage and a tear on the vessels, and that might cause a stroke. And these patients are challenging. They present with a funny neck, headache, neck pain, headache, goes retroorbital, lasts for a few days, and they have the stroke. Usually, a carotid ultrasound would be the best way to identify them. And finishing on management, atrial fibrillation. If the patient has an atrial fibrillation, needs to be anticoagulated. I will go to the last line. Warfarin is just indicated for mechanical valves or severe mitral stenosis with atrial fibrillation. The NOACs, we are not on the payroll. They are fantastic. They change when they prevent ischemic events. And actually, dabigatran is the only one that is superior compared to warfarin to preventing a stroke. The other ones were powered as non-inferior, but all of them are safer. They are less likely to have hemorrhages. And from my end, the hemorrhage changed. The hemorrhages with warfarin, they were catastrophic. And now the hemorrhages that we see with the NOACs, they are much smaller. And with dabigatran, we can even reverse it, which is fantastic. And we have the reversal in most of our rural sites. And the gut feeling of the neurologist is not good enough to decide anticoagulation. We need to prove atrial fibrillation. It's a pain, I know, but we need, as there were 3 trials that they were comparing how does the gut feeling of the neurologist compare on treatment, meaning they had these patients on the left that they are embolic looking, normal vessels, and they said, okay, what about randomizing these patients to antiplatelets versus NOACs? Is there a benefit? Do we need to prove atrial fibrillation, or just an atrial fibrillation looking a stroke might be enough? And actually, the 3 large randomized clinical trials, they proved to be negative, and they proved that the neurologist might think that this comes from the heart, but doesn't seem to translate on a benefit of anticoagulating these patients. These trials were negative for secondary prevention of ischemic events, meaning these patients had as much as recurrent strokes on the antiplatelet group compared to the NOAC group, and actually had an increased hemorrhagic risk in the NOAC group, which means it is sometimes, I find it not painful, but it's a long road to identify atrial fibrillation and requires a lot of resources, but it needs to be captured. There is a need for it. This is a bit of a summary of how manage TI or strokes. Exclude the ICHs and hemorrhages with a non-contrast CT. Determine the mechanism. Take a look at the neck, carotids. Atrial fibrillation, just now, we need to identify it. If we find it, we anticoagulate. And in those young patients, cryptogenic strokes, worth to go through PFO, assessing of PFO. And I didn't mention in the younger actually than 50, we do also as well thrombophilia screen. If the patient is not on atrial fibrillation, the combination of clopidogrel and aspirin for 3 weeks would be the best way to go. And refer to the clinic, and I'll talk now about the clinic, and definitely don't forget, please, about all the other secondary prevention, as I put there probably on the last of the sentences. Don't forget the lifestyle risk factors. In this one, we need you more than ever. Like our intervention on these patients is limited, and what we can give around advice about alcohol intake or strategies about stopping smoking is pretty limited. Important to know the driving restrictions, especially from ED perspective. TI 2 weeks, 4 weeks for a commercial license, and minor stroke 4 weeks, 3 months for commercial. And this is what I thought I was coming, the referral pathway. We have actually 6 sessions per week at the John Hunter Hospital. You have the fax there, and you can address to my colleague Neil, my colleague Alvin, or myself. We do a weekly telestroke clinic at Tari, and that's important. If you are referring the patient to us, refer to the John Hunter Hospital. You can refer it, or otherwise you can send an email to Emma McCartney, the stroke coordinator there. You can refer to us, that's easier. Everything refer at the John Hunter, but just flag, hey, the patient lives at Manning area. So then we know that we need to book this in Manning area. Same for Maitland. We started to do fortnightly clinics there. So if you just flag that the patient is from the Maitland area, you make our life much easier. For example, today, we had a patient from Manning area booked at the John Hunter. I had to cancel the appointment last minute because otherwise the patient would come, drive for 2 hours and back. So these kind of things otherwise happen, and it's our fault at the time of triaging, but we triage quite a few. And if you have a question, Don't forget that there's an in-hours stroke fellow at the John Hunter Hospital, and there's always going to be a stroke neurologist on call. But definitely at least in hours, you have the stroke fellow supervised by the consultant to get through all the questions that you might have in the clinic. And I'll finish with a very quick vignette. Something different. This is a real case. So far, I think that I've done, I tick my box of all the things I want to tell you, but this is something that we are very passionate about. The unexplained level of consciousness. And this is difficult. This was a patient that we've seen a couple of years ago. It was a 44-year-old female with a very nothing on the medical history, anxiety, and she felt unwell, vomiting, collapsed, hit her head on the bathroom floor. Arrived to the John Hunter 60-90 minutes after the onset and already has this in the picture. It was cerebrating and GCS of 5. It was intubated. The bloods were normal, 37.2. Big differential there. This is the non-contrast CT done at that point. There's something there for me, and perhaps some of you already see it. And probably that is subtle, but that basilar and that vertebral is hyperdense. This is hyperdense, which tells you there is a clot sitting there, clot on the basilar. The differential diagnosis was ample, meningoencephalitis, seizures, drugs. There was a bit of query of many things happening, social involved. It was admitted in the ICU. It was considered that was fitting. The LP was normal. The patient was extubated the day after, but needed to be reintubated the day after that. And the patient developed a pretty nasty, very nasty, very, very nasty brainstem stroke that you can see there. And this, unfortunately, this is in the MRA. You can see that the basilar was occluded, leaves you towards a locked-in syndrome that you might be very familiar in these patients. They are able just to communicate with blinking. As it's traumatic, and this is a kind of a stroke that I just want as a vignette to keep in the back of your mind. If you have a decreased level of consciousness that you are unable to explain otherwise, do a CT angiogram, do an urgent CT angiogram from ED, wherever you are. These are rare strokes, 3 to 5%, but the outcome with no treatment, the mortality is 70 is very generous, is close to 90%. The deficits can be usually the story is vague. That's a problem. It's vague. It's a vertigo, it's a nausea, it's a vomiting, it's a bit of incoordination. Look, if you have any questions and you don't have you have a decreased level of consciousness, sudden like that, like this case, and you don't have any other clear explanation, the patient is not febrile, there was no drugs, there was no seizure, CT angiogram is indicated, and just confirm that that basilar artery is clear. As we've seen these patients a couple of times per year missed, and they're catastrophic. They are terrible outcomes, and they are awful, to be honest. It's something that whatever we can do to avoid one of these cases, that would be very, very important. I think that's all for me. That's my email, so definitely you can, if you have questions on the track, send me an email anytime. I wonder if you have any, firstly, thank everyone for listening at my Spanish for 2 hours. And just asking if you have any final questions.
Thank you so much, Carlos. That was great. There is a question. If greater than 3 weeks to get to the high-risk stroke service, is longer than 21 days of dual antiplatelet treatment warranted until they can be seen?
Not really. That's a great question. As I didn't show you that. I should have bring that. I'll do it next time. I promise. You can see how the hemorrhagic risk starts to be exponentially increased beyond these 3, 4, 5 weeks. And actually, when you look at the hemorrhagic risk in these trials, when you keep a patient up to 90 days on the combination of aspirin and clopidogrel, the hemorrhagic risk is greater than having a patient on a NOAC. So no, definitely instruct the patient to 3 weeks on the track, stop one of the antiplatelets. I didn't mention, if the patient was already on aspirin, we do tend to keep them then lifelong on clopidogrel and the other way around. No strong evidence around that. There's a few small trials, but that's usually how we will tend to do. Any other questions, Jackie?
One from earlier, would you thrombolyze someone with mild symptoms such as slurred speech?
Look, that's a good question. Slurred speech by itself, quick answer, no. But sometimes you might have a patient with a large vessel occlusion with great collateral circulation that has mild symptoms now, but the imaging is telling me unless I unblock that vessel, the symptoms are going to fluctuate and get worse. That's, again, one of the advantages of doing perfusion, as he's able to point me towards those patients. But this is a rare event, it's a minority. So long story short, no, not really. Slurred speech is how disabled is going to be slurred speech compared to, hey, we keep the risk of thrombolysis pretty low, but it still is a 1%. I'm not sure if someone would like to sacrifice a 1% risk of a hemorrhagic risk for a slurred speech.
Thank you. There's no more questions, but that's a very comprehensive presentation. Thank you so much.
I know,
for your time.
I went through everything. Thanks everyone for the patience. Thanks so much.
Thank you so much, everybody, for attending. Carlos, thank you so much for giving up your time. Jackie, thank you so much for doing the questions. The recording will be up on the website on the PHN's webpage under the Education Library. Should be up there by tomorrow afternoon. Thanks, everybody. Don't forget to fill in the evaluation. Just something that we do have coming up is some registrar dinners, one in Tuncurry and Armidale, Tamworth, Inverell and Narrabri. Keep an eye out for emails from the education team, and we'll see you all next time. Thank you. Good night.
Bye-bye.